Good evening, everyone. How are you all? All right. So we're going to finish orthopedics today, hopefully. So have you guys started orthopedics preparation yet? Slowly. Yeah, I know. It will take time, that's fine. But try to finish one at a time, especially go through what we have discussed at least. Because I always say that if you do a live session, try to finish that particular topic within few days. The reason behind it is that because the informations will still be there in your head. And if you just give a read from either the notes or from JM, you will easily finish finish the topic within shortest time. But if you keep it like, let's say that if you keep it for 1 week, then whatever I discussed, you will not remember. And you might again end up listening to the recorded class. Okay. So that's that. Just 1 second. Let's start. So we're going to start with the pain in the arm and hand. Okay. Pain in the arm and hand. This is like a long chapter. So this is chapters 53 in your JM 8th edition. So first of all, we're going to start with the pulled elbow. So I think we did discuss about it a little bit. So pulled elbow usually occurs in children under 8 years of age, especially when an adult applies a traction force on the wrist like this. So if you pull up the child at the wrist while the elbow is extended like this, sometimes what can happen, the head of the radius can be displaced through the elbow joint, like this one you can see, and the child will be in severe pain because of that. So child will be crying because of pain, refuse to use that arm, and most of the time, what you will find out, this will be the main finding. So elbow will be flexed, and then forearm will be pronated. So the child will not allow you to do the supination. So the hand position is really important. So elbow slightly flexed and the arm pronated or forearm pronated. That's the time you would think of pull elbow. There is no necessity of doing X-ray to confirm it. It's a clinical diagnosis. Once you suspect something like that, you can do some, like you have to reduce this radial head back into the elbow joint. Okay, that's the treatment. Next, tennis elbow. Tennis elbow is a very common cause of arm pain, especially elbow pain. So what happens in tennis elbow? The other name of it is lateral epicondylar tendinopathy. Sometimes we also call it lateral epicondylitis. Let's see if we have got a picture. So if you see over here, you can see that this is the medial part of your elbow. So in this area, you will get medial epicondyle, and over here, you get lateral epicondyle. So the extensor muscle of the forearm, which is this one, the tendon of that muscle will be attached to the lateral epicondyle. Okay. So if a patient does a lot of activities involving frequent, what happened? Okay. Can you guys see my screen? There was a glimpse. Okay, that's fine. Moving on. So I was discussing that in lateral epicondylitis, the extensor muscle of your forearm, which is this one, the tendon get attached to your lateral epicondyle. So if a patient does a lot of activities using the extensor muscle of the forearm, like playing tennis, the tendon can get strained. And sometimes due to that, it can get inflamed. And that is what we call as tennis elbow or lateral epicondylitis. Okay. So how the patient will present to you? So patient usually middle-aged patient, and the common occupation related to this is carpenter, bricklayer, these people. And very commonly, it can be associated with tennis players. So pain at the lateral aspect of the elbow and pain in elbow during gripping movements. So turning the taps, turning door handles. So patient will come to you saying that whenever I try to open my can or open the bottle or turning my taps, I feel pain on my elbow. That's a classic picture. And then if you press on the lateral epicondyle, you can get a localized tenderness over there. And because this is the extensor muscle tendinopathy, right? So in this case, what will happen if you do a passive stretching of the wrist like this one? So see that this is a passive stretching of the wrist. Patient will be complaining of pain on this area. So that's the most important sign. So we say that there are three most important physical signs in here. So tenderness at the lateral epicondyle, pain on passive stretching of the wrist, and pain on resisted extension of the wrist. So you ask the patient to move the wrist upwards against your hand. Moving the wrist upwards is extension, and you are actually giving resistance to the patient. So this is called resistant extension of the elbow. Same with the resistant extension of the wrist. Patient also will be complaining of pain at the elbow joint. Okay, so these are the main three signs of lateral epicondylitis. Elbow movement will be fine. It can run for even 2 years. So it's a chronic course of pain. The main management is rest from offending activity. Sometimes you can also give some painkiller and exercise. Okay, so this is the treatment: rest, analgesia, exercise. In some point, you can also go for a steroid injection. Very commonly, we advise the patient to put a below elbow band. So about 5 to 7 centimeters below the elbow, if they put a elbow band, that will also protect that tendon. Okay. And the last resort is surgery, which is rarely needed. After that, you have got olecranon bursitis. So in between, so if you palpate your elbow joint, you will find out there are 3 bony prominence. So you know about the lateral and medial epicondyle. Just in between the lateral and medial epicondyle, you have got your olecranon process, right? That olecranon process also has a bursa, which is a fluid-filled sac. So this is the one. So you see over here, this one is what we call as olecranon process. And it has a bursa, which is a fluid-filled sac. Now, obviously, if there was nothing in here, it can easily get traumatized, right? So to protect this bone, there is a bursa over here. Sometimes patient can get inflammation of this bursa, and that is what we call as olecranon bursitis. So it's a localized swelling of the bursa, and patient sometimes comes with a trauma at the elbow joint. Sometimes even it can be related to arthritic condition like rheumatoid arthritis, gout, or even sometimes it could be septic arthritis such as infection. Okay. Acute olecranon bursitis presents with redness and warmth, and also sometimes patient will be in severe pain. So pain, hot to touch, and red, that's the time you would be thinking about acute bursitis. The problem is that when you think about septic bursitis, if there is no history of any trauma or there is nothing there, but patient having fever and it's a very acute onset, you should think of possibility of a septic bursitis. If you suspect septic bursitis, you need to send the patient to the hospital, and they will aspirate the bursa fluid, send it for the microscopy and culture, and they will try to find out if it is an infection or if there is a crystal into the joint, which can suggest gout. So they should be able to say what's going on there. Okay. So acute olecranon bursitis can be due to just trauma, but very important to make sure that it's not a septic bursitis. If you suspect septic bursitis, the patient needs to be in the hospital, have a bursal fluid examination or aspiration, and then start antibiotic. If it's a traumatic one, then most of the time we don't need to worry about it. Just ask the patient to protect this elbow area and then give some painkiller. They can use some hot or cold pack for the pain and swelling, and then gradually it will resolve. Okay, so that's traumatic olecranon bursitis. So far you have done the elbow. Now coming to the wrist. At the wrist joint, if a patient complains tingling numbness sensation or pins and needle sensation, you will be thinking about some nerve compression. The commonest entrapment or commonest neuropathy in the hand is median nerve entrapment at the wrist joint. So this is your carpal tunnel. Underneath this carpal tunnel, the median nerve will pass through and it will supply your 3.5 fingers. So thumb, index finger, middle finger, and half of the ring finger. This will be supplied by your median nerve. And how about this 1.5 finger? That will be supplied by ulnar nerve. Okay. So in case of median nerve entrapment under the carpal tunnel, patient will complain a pins and needles or tingling numbness sensation involving these fingers. Okay, so that's what we call as carpal tunnel syndrome, which is an entrapment of the median nerve in the carpal tunnel. Patient complains pins and needles affecting their fingers. There might be a lot of causes of carpal tunnel syndrome, so go through this in your own time, but the common ones is diabetes, sometimes hypothyroidism, pregnancy itself can cause it, occupational injuries, rheumatoid arthritis. So very commonly, patient will complain waking up from their sleep at night with pins and needles affecting their fingers. They get out of the bed, shake their hands, and then the pins and needles subside. So that's a pathognomic sign of carpal tunnel syndrome. How to do diagnosis of this? Usually you can diagnose this by some clinical examination. So the common physical exam that we do is called Tinel test and Fallon test. So in Tinel test, you just tap over this carpal tunnel and patient will complain pins and needle sensation on the fingers. So that's Tinel test. And then there is Fallon test, which you don't need to know. Just remember the name of it. There is also another test that we can do, which has the highest specificity of all tests, is 2-point discrimination. So remember these 3 tests name only. Sometimes question asks that you have done TNL tap test, but what is your confirmatory test that can confirm the diagnosis of carpal tunnel syndrome? The confirmatory test is nerve conduction study or electromyograph, because this is a neuropathy. A nerve conduction study or EMG is the best test. Sometimes they can ask you that what is your next most appropriate investigation for this patient? Next most means initial. We never send a patient to a nerve conduction study before doing a simple ultrasound. Sometimes ultrasound can even comment on carpal tunnel syndrome. So your initial investigation should be ultrasound, and then the best or most appropriate should be NCS or EMG. Okay? Treatment. For mild cases, simple rest, splinting, particularly at night, is sufficient. So ask the patient to rest from offending activities, splinting at night. That should help. Some analgesia, hot pack, that can be given. And sometimes, if it is really bad, like even after doing these things, still patient is in pain, you can send the patient for a carpal tunnel steroid injection. And the last resort is surgical release, which is which is necessary for a patient who has got like severe carpal tunnel syndrome refractory to other treatment. Systemic evidence-based reviews indicate the benefit of short-term oral steroid and local steroid injection. So you can also give some oral steroid and local steroid injection. This is usually the best choice. Any question, guys, for carpal tunnel syndrome? So initial management is simple rest, splinting, and then sometimes even some little bit of painkiller you can give. But if the question asks, what is the best treatment? The best initial treatment is obviously the steroid injection will be really good. And for long term, surgical release will be the best. But surgical release is our last resort. Next. Yeah, so a steroid injection into the carpal tunnel. That's it. This kind of question doesn't actually ask you most appropriate treatment because there is no most appropriate treatment for this. It's a step-by-step treatment. So question usually asks you that, what is your next most appropriate treatment? So they will give you some that you have already tried, simple rest and splinting, but still patient is in pain. So what do you want to do next? So usually this is how the question comes, okay? So in those situations, you will obviously start with simple rest and splinting. After that, our next option will be a steroid injection, and then after that, surgery. The test name is Tinel tap test, Palin test, and 2-point discrimination. So first we will do clinical examination, then we do ultrasound, then we do nerve conduction study. Next, trigger finger or trigger thumb, also known as flexor tenosynovitis. So have a look on the picture. So this is what we call as trigger finger. As you can see over here, that in trigger finger, the main issue is flexor tenosynovitis. So that means the tendon which helps your finger to do flexion, that becomes problematic. So in the fingers, the common work-induced condition is stenosing flexor tenosynovitis, also known as trigger thumb or trigger finger. So what happens in here? So first of all, in these cases, many times trigger finger can be associated with occupational injuries, but we should also look for this common association, which is type 1 diabetes, rheumatoid arthritis, gout, hypothyroidism. In middle age, these tendons, which are rapidly and constantly being flexed and extended, can undergo wear and tear. And sometimes it can also causes a swelling, edema, and painful inflammation, followed by formation of a nodule on the tendon that triggers back and forth across the thick, sharp edge of the pulley. So what does it mean actually? That because obviously along the edges, the patients do a lot of activities on their hands. And these tendons goes for wear and tear. Sometimes it will become inflamed and it will form a nodule on the tendon. These patients may present with a finger locked in the palm of the hand. So they will come to you that, doctor, my finger is locked and I can only passively extend my finger. So patient will use their other hand to passively extend it. So immediately you will know that this is a trigger finger. Okay. Sometimes if you place your palm of the finger over here, you can even feel a crepitus of this pulley. The most commonly involved is the thumb and fourth finger. Okay. So it's very easy to diagnose. If a patient comes to you saying that, doc, my hand is just always like bended and I need to open it up or I need to extend it by myself. If that is the case, that's a trigger finger, you immediately know. For trigger finger, it's a clinical diagnosis. Just by looking at it, you will know that this is a trigger finger. So what you will do in this situation, you can start with oral NSAID that can provide the pain relief. Although surgery is simple and effective, treatment by injection is often very successful. So many times you can go for a steroid injection under the tendon sheath, not into the tendon or not into the nodular swelling, but under the tendon. You can go for a steroid injection, and many times that's it. That can help the patient a lot. So trigger finger, your main treatment should be a steroid injection under the tendon sheath. And success rate is 70%. Sometimes if one injection doesn't help, you can repeat it after 3 weeks. But even after doing multiple steroid injections, still it is ongoing, then you can go for surgery. Moving on to Dupuytren contracture. Dupuytren contracture is a fibrous hyperplasia of the palmar fascia, which causes nodule formation and contracture of the fingers. So what does that mean? So you can see this is the palmar fascia. So thickening of the palmar fascia. So if the palmar fascia get thick, that will also contract your fingers. So that's what we call as Dupuytren contracture. So thickening of the palmar fibrous fascia causing contracture of the fingers, resulting in a fixed flexor contracture of the fingers. The most common finger which gets affected is these two fingers. Okay. So it occurs in male over 65. Cause is unknown, but sometimes it can have genetic predisposition. It is associated with smoking, alcohol, liver cirrhosis, COPD, diabetes, epilepsy, and heavy manual labor. So patients who use a lot of vibration tools, they can have this very commonly. So what's the treatment? According to JM, they say that if the nodule is growing rapidly, injection of a steroid or collagenase into the cord can be beneficial. And if there is a significant flexion deformity, then surgical intervention is indicated. This comes in exam, so you will need to know a little bit more. So let's go to the ortho bullets. Treatment. So first we start with non-operative treatment. So you can send the patient to the physiotherapist for some exercise, but the management can be sometimes you can do injection of collagenase. So that's one option. The needle aponeurotomy that can be done. The main thing you need to remember that this conservative approach is usually done if a patient has got less deformity. If a patient has got PIP joint flexion deformity, then that patient will need surgery anyway. So what do I mean by that? If we look over here, this one, you can see that there is obviously a contracture, but the PIP joint is fine, right? So that this patient doesn't have a significant deformity yet, and PIP joint is not involved. In those situations, you can initially start these patients with collagenase, steroid injections, or even needle aponeurotomy. Any of this is fine. But if it is PIP joint having contracture, or if the MCP flexion more than 30 degree, that patient will need surgical resection or fasciectomy. That means the fascia that has got fibrosed, that fascia needs to be removed. Okay, so the picture that you see here, this one obviously having a PIP joint deformity. So this finger will need surgery at the first. That means the first line treatment for this would be surgical fasciectomy. But for this patient, there is only MCP joint flexion which is still okay, you can try with the like a non-surgical approach. So any of this is fine. Collagenase will be okay. You can also go for a steroid injection. That's fine. Okay. So that's the treatment for dequervant tenosynovitis. What I have seen that sometimes they give you a picture of that PIP joint flexion deformity like this one, and they ask you what is your most appropriate treatment. So now you know it's a surgical intervention, which is fasciectomy. Moving on to dequervant tenosynovitis. Dequervant tenosynovitis also, it's a work-induced inflammation of the tendon. So dequervant tenosynovitis is a tenosynovitis of the wrist dorsal extensor compartment tendon. So let's have a look what exactly that means. Yeah. And just copy paste and keep it in here so that you can understand. So what you see here, so see that at the base of your thumb, so this is the tendon, right? And then there is a tendon covering, okay? So in flexor, in dequervant tenosynovitis, this tendon, which actually supplies your thumb, or which actually moves your thumb, that get inflamed, okay? So let's come back. So which tendon is usually the one that get inflamed in here? That's the extensor tendon. So the one that helps with the extension of your thumb. So that's called extensor. Pollicis means thumb, and brevis is the smaller one. So extensor pollicis brevis tendon and abductor pollicis longus. So abductor means the one that helps with the abduction of your thumb. So now you know that two tendon which helps with your extension and abduction of the thumb that gets inflamed in dequervant tenosynovitis. And this is the tendon which passes through the wrist and goes to the base of your thumb. It usually happens in patient who does a repetitive movement of the thumb and the wrist, especially assembly line workers such as staple gun operators. Typically middle-aged, pain will be at the base of the thumb, pain during pinch grasping. So anything which involves movement of the thumb will cause pain. Okay? And it's a dull aching pain. Sometimes it can be really bad. What's the diagnostic triad of it? Tenderness with possible crepitation on palpation over the radial styloid. So let's have a look. So just over this area, there is radial styloid process. So you can get tenderness on the radial styloid. You can even get a firm, tender, localized swelling on the area of the radial styloid. So you can either get a firm swelling or you can get tenderness. And then there is another test that we do called Finkelstein sign that will be positive as well. You don't need to know how to do it. Just remember the name. Treatment, because this is a stress injury. So it happens because of work. So patient needs to take a rest and avoid the positive stress. Sometimes patient can be on a custom-made thumb splint, which immobilize the thumb and the wrist. You can give a trial of anti-inflammatories for a few days. Local long-acting steroid injection can relieve and may even cure the problem. Okay, so you can also go for a steroid injection into this tendon, and last option is surgery. Good. So that's dequervant tenosynovitis. So if a patient comes to you saying that whenever I move my wrist, I feel pain on my wrist, then you will be thinking about the D quadrant tenosynovitis. Mallet finger. Mallet finger is important. It comes in exam. So it's a common sport injury caused by ball, like football, cricket ball, unexpectedly hitting the fingertip and forcing the finger to flex. So it's a hyperflexion injury to the distal phalanx. So let's have a look. So if a cricket ball hit the distal end of your finger, it will cause a hyperflexion injury to this tendon. And what happens in here? There might be a rupture or avulsion of the extensor insertion into its dorsal base. So basically what happens that the tendon which helps your finger extension at the DIP joint, that can get ruptured. Okay. So that causes this classic swan neck deformity you can see over here. So it's a very typical scenario, hit by a cricket ball or football, and now patient unable to do extension of this DIP, like extension of the finger at the DIP joint. That's mallet finger. So what you have to do, you need to extend it. So maintain hyperextension of the DIP joint for 6 weeks. And usually you can just put this kind of non-stressed adhesive tape like this, and that should be enough. Okay. So that's all that you need to know from this pain in the arm and hand. Any question, guys? Okay. Moving on to hip, buttock, and groin pain. First of all, I kept this part of the hip pain in children for today. So children can present to you with a lot of hip related issues. So these are the main ones that we are looking for. So developmental dysplasia of the hip. Patient can have transient tenosynovitis, Perthes disease, septic arthritis, osteomyelitis, slipped capital femoral epiphysis, and sometimes even pathological fracture. This is a very important chart to remember, and these kind of questions come frequently in exam. And you should also go through this from RCH guideline. So DDH is common in between 0 to 4 years of age. Between 4 to 8 years, common is transient synovitis and Perthes, and a little bit more teenage group, 10 to 15, gets SCFE. All of them will have the same complaint, limping. Some can present with hip pain, some can present with knee pain. And they will have limited movement of their hip. In DDH, the main movement that will be restricted is abduction of the hip. Transient tenosynovitis, almost every movement will be sore, but mostly abduction. Perthes, abduction and internal rotation, and SCFE, especially internal rotation. Do we need to remember this? No, you don't need to remember that. Just remember, most of the time, abduction will be impaired. Plain X-ray. In DDH, we normally don't do X-ray. We can do ultrasound. And then there are some X-ray finding for all of the others. We will come across to that just in a bit. Let's start with developmental dysplasia of the hip. Developmental dysplasia of the hip, previously we called them as congenital dislocation of the hip. So what happens in here is the femoral head dislocates posteriorly and superiorly. So if you remember this, so what you see here, so this is obviously the pelvis, right? And that's your hip bone or hip joint. And you can see in here the hip joint or the femoral head is into the socket, right? So that's normal. But if you look on this side, you can definitely see that this is the socket and this is the femur. So this is displaced. So when it is displaced like this, that's what we call as developmental dysplasia of the hip. And most of the time it is displaced posteriorly and superiorly. So who are the risk factors? The risk factor is 5X, female child, firstborn, family history of DDH, foot abnormalities or funny deliveries, especially breech or transverse lie. These two, the children usually gets DDH a lot. So if there is a history of breech delivery, and then normally at the right now we usually just do a screening ultrasound for every child who gives who gives birth as a breech. Okay, so because it's common that they can have a developmental dysplasia of the hip, and also children who goes for cesarean section or oligohydramnias. So it is common in female children, and most of the time unilateral, sometimes even can be bilateral. This one is unilateral. But in here, you can see the X-ray. But do we do X-ray? No, we don't need to do X-ray to diagnose DDH. So if there is an X-ray given by any chance, the easiest way to know is that look at this Shenton's line. The Shenton line starts from the medial aspect of your femur, right? And goes through the middle aspect of the neck of the femur. And then just follow a straight line through the pubic rami. Now, if you look on the displaced one, you can see that this line and this line is way displaced, right? So this is not a straight line anymore. So that's Shenton's line that you can get in DDH child. A lot of other lines is there. You don't need to go through that much. So what we normally do is that every children will have some neonatal checkup. So immediately after birth, there will be a neonatal checkup. Then 6 weeks after birth, there will be a neonatal checkup. So during those checkup, usually we are looking for this kind of developmental dysplasia of the hip routinely for every children. And that time we do this ortolani and Barlow test. So this is just an examination. This ortolani and Barlow test can give you a basic idea that if this child can have DDH or not. And usually the initial 2 months of life, you can do this too. After 2 months, usually this test will be negative. So after 2 months, what will be your investigation if you suspect DDH? That time we will use ultrasound. Okay, it is more sensitive than clinical exam. So if clinical examination shows a possibility of DDH, then you can confirm it by doing an ultrasound. Ultrasound usually can be done up to 6 months. After 6 months, then you can go for an X-ray. So you can see here that every baby should be examined for DDH during the first day of life and then before discharge from hospital at the 6-week checkup. Ortolani and Barlow remain important means of detecting this kind of issue, but ultrasound is more important and recommended for high-risk babies. So this is the screening test. Plain X-ray has no place in the DDH in the neonatal period. Ultrasound is recommended. And if you suspect it, you need to refer the child to an orthopedic pediatrician, because if not detected early, sometimes this can result in a long-term problem, like osteoarthritis in children. Okay, and children will obviously not be able to walk because it's displaced. So delayed walking can be a presentation also. So treatment 0 to 6 months, you can apply pelvic harness. 3 to 18 months reduction and pelvic spica cast. More than 18 months open reduction and osteotomy. Do you need to remember this? No. Usually I have never seen these kind of questions coming in exam because you're going for ANC exam and this is a junior doctor examination, and this kind of treatment will never be done by you. It will be done by an orthopedic specialist. So usually you don't need to even know this treatment. Just know what can be done at least. The problem with this is that even after treatment, some children can have acetabular dysplasia. That means underdevelopment of the roof of the hip joint. And that can cause a premature osteoarthritis. Okay, so that's your DDH, that important for exam. Moving on to Perthes disease. After 6 months, X-ray will be recommended, yes. And if it comes to exam, I would say that please make sure you also read the RCH guideline and then make a note on this treatment part. Okay, but most of the time, the treatment will be similar like this. So initial 6-month pelvic harness, 6 to 18 months, we will go for pelvic spica and cast, and after 18 months, possibly open reduction. Perthes disease. So Perthes disease, it results in the femoral head becoming partly or totally avascular. So it is also known as avascular necrosis of the femoral head. Okay, so that means the femoral head is not getting enough blood supply, which is causing the avascular necrosis. It's common in male child between 4 to 8 years, and it also presents with hip pain, groin pain, and presents as a limb. Sometimes even they can come as a knee pain, and they will have limited movement in abduction and internal rotation. If you suspect something is wrong, you will do an X-ray. And on the X-ray, it will look like this. So what you see on the right side, well-developed femoral head, right? So femoral head is well-developed. This is the growth plate over here. Now, if you look over this left side, what you see? It's a complete destruction of the femoral head. And that is what we can get in avascular necrosis of femoral head or Perthes disease. Okay. So X-ray finding, you can go through that. Management, refer urgently, provide crutches, and choice of treatment will be decided by the orthopedic surgeon. Left untreated, it can cause eventually osteoarthritis. Next is transient synovitis. Transient synovitis is also known as irritable hip, and it's one of the commonest presentation of hip pain in children. So it's a self-limiting synovial inflammation. So transient means temporary, and you know that synovial fluid inflammation is synovitis. So what happens in this case, children between 4 to 8 years of age usually gets this. Many times children say that they had an initial few weeks of viral flu-like illness. And after that, suddenly the child is complaining of hip pain and limping. Child is able to walk, but with some pain. And they will have limited movement, especially abduction and rotation. Okay? The problem with transient synovitis is that it can easily get confused with septic arthritis. So if we get a child having fever and child suddenly can't move the hip at all, even if there is a recent history of viral flu-like illness, we will consider that child to have a septic arthritis until we can prove otherwise. So febrile child looks unwell, having limited movement of the hip and very acute, we should not just think it is a transient synovitis. It can be, but we have to make sure that we rule out septic arthritis. Okay, so that's important. So in this transient synovitis, if you do blood test and X-ray, it will be normal. Sometimes you can do an ultrasound and that will show fluid on the joint. So that's the fluid accumulation causing this transient pain and inflammation. Usually it will settle within 7 days without any complication. Okay, treatment, refer early, bed rest, use crutches and analgesics, because many times this can be a presentation of Perthes disease. So what we advise, even though you thought it as a transient synovitis, do a follow-up X-ray in 4 to 6 months to make sure that this presentation was not a Perthes disease. Okay, If you suspect it as septic arthritis, you need to send the patient to hospital, and patient needs to have an aspiration of the synovial fluid for microscopy and culture. Okay, so transient synovitis means that a recent history of viral flu-like illness or a trauma, suddenly child is not limping and not moving the hip joint, then we should suspect transient synovitis. Okay, but if the child is febrile, having like severe limitation of movement, you can see in here, child can usually walk. Septic arthritis child will not walk. They will be in severe pain. So if it looks unwell or suspicious, you should consider it as a septic arthritis. We can't be sure actually. So unless the child looks very well and it's not like a very acute presentation, child is walking, little bit of limited movement. That's the only way you can be sure. Otherwise, you will not be totally sure in this case. So best idea is to refer. But if your stem says everything, like ultrasound shows fluid on the joint, in those situations, yes, you can think that it is a transient synovitis. SCFE, slipped capital femoral epiphysis. So what is this SCFE? It is one of the common problem for children who is between 10 to 15 and they are obese. So most common in the oversized and undersexed prepubertal boys. So children usually present with limping, and they can also come to you with either hip pain or knee pain. Okay, and the main limited movement will be internal rotation. So SCFE means slipped capital femoral epiphysis. So it's a displacement of the capital epiphysis of the femoral head. The problem with this is that when it is displaced, the femoral head can develop avascular necrosis, because when it is displaced from the normal position, I will show you how it looks like, then you will understand. Oh, there was a good X-ray. Let me show you a good X-ray that will make sense. If you look on this X-ray, you will understand what I'm talking about. So you can see on here that this is the femoral head, that's the epiphysis. Okay, it's not displaced, it's normal. But now you look, so this is your femur, and that's the femoral head. See that femoral head has displaced? When femoral head displaced like this, that's what we call as SCFE. Okay, so, and the problem is that when it is displaced, it will not get enough blood supply. Eventually, it will become a avascular necrosis or Perthes disease. So diagnosis of the condition before major slipping is important. So you know the clinical features. Any adolescent who is usually obese with a limp or knee pain should have X-ray of both hips. So the main thing is that even if a child having knee pain, so pain in the knee, still you are going to do both knee and hip X-ray. Because many times children can't understand from where the pain is coming. So adolescent boys complaining of knee pain should have X-rays of their both hips also. Okay, so that's the main thing that you should not forget. Many times, if it is just an early onset, you will not get that slipped pattern. Like this one, the X-ray, this is actually grade 4 or 3. So you can see it's already slipping happening, right? Now, this one is the early onset. So we say that if you draw a line across the neck of the femur, like this is the neck of the femur, it should traverse through the femoral head. It is traversing through the femoral head, that's normal. In case of a displaced femoral epiphysis, if you draw a line from the back, from the neck of the femur, it will go above the femoral head. Okay, so it doesn't necessarily need to be slipped. Even this one is SCFA. Okay, so management refer to orthopedic surgeon. If acute slip, sometimes gentle reduction with traction can be done. And then once reduction is done, then a pinning will be performed to keep the femoral head in place. So that's SCAV. Next, septic arthritis. Septic arthritis of the hip should be suspected in all children with acutely painful or irritable hip problems. So that gives your answer, I think, who asked it. So Arusa, so this is the line from where I was coming. So any children who is having acutely painful or irritable hip problems, we should consider the likelihood of septic arthritis. Sometimes this patient might not even have fever, might not be that much unwell looking, but still they can have septic arthritis. Okay, so the irritable hip syndrome should be diagnosed only after a negative investigations, including plain X-ray, ultrasound, full blood examination, ESR, and bone scan. Needle aspiration has to be considered, but irritable hip is often diagnosed without it by observing the child in hospital. If there is a deterioration or elevated temperature develops, needle aspiration with or without arthrotomy is indicated. So that's what I was talking about. This is a very complicated question because in exam you get something like that. And you need to be a safe doctor rather than be a very confident doctor. Being overconfident can put some patients in risk. But being a safe doctor will put everyone at a safe place. That's better. So especially in case of children, because they can't say too much about their presentation, we don't take risks. So for septic arthritis, the main thing is that if a child having acutely painful hip pain or acutely painful or limping, we should not just diagnose them with transient tenosynovitis unless we have all the investigations done. So what will we do? We will do a plain X-ray of the hip, we will do ultrasound, we will do blood test, and then sometimes if it is not very unwell child, they can just keep the child in hospital. But if they deteriorate, then they go for this needle aspiration with or without arthrotomy. Okay. And for septic arthritis, the children needs to be on IV antibiotics. So that's your septic arthritis. Now we are moving to elderly hip and buttock pain. First of all, osteoarthritis of the hip. So osteoarthritis of the hip is the most common form of hip disorder in elderly. So what is the clinical feature of osteoarthritis? Usually after 50s, it's an insidious chronic onset. At first, pain will get worse with activity and relieved by taking rest. And then the nocturnal pain and pain after resting. So initially, patient will say that if I do a lot of activities, I get the pain get worse. When I take rest, pain gets better. When it gets a lot worse or more advanced, then patient also starts to get night pain. And even after resting, it doesn't do any good. And then they start developing stiffness on the joint, especially in the morning. Okay, so that's osteoarthritis of the hip. So few things can be found in examination: antalgic gait, which is painful gait, and sometimes their gluteal or quadriceps muscle can get wasted. The first hip movement that will be restricted is internal rotation and extension. This come in exam, so remember it. So the first movement that will be lost or restricted is internal rotation. Okay, and eventually all movements will be affected. Because this is a chronic insidious condition, there is no specific treatment for it. And it's just a degenerative joint problem. So as the age grows, there will be wear and tear of the bones, right? That's osteoarthritis. So what you can advise the patient that there is no specific treatment for it, but they can use some paracetamol, very short course of NSAIDs, physiotherapy. They can also go for hydrotherapy. So there are lots of exercises that can be done. Okay, so that's your osteoarthritis of hip. Next, greater trochanteric pain syndrome. Greater trochanteric pain syndrome. First of all, you need to know where is the greater trochanteric. See this one. So this is your greater trochanter. Some patients can have greater trochanteric pain syndrome. So a patient who is coming to you with a hip pain at the lateral aspect of the hip. And sometimes the pain will radiate down the lateral aspect of the thigh. Okay. That's what we call as greater trochanteric pain syndrome. So a patient who has just a lateral hip pain and that radiates down to the lateral aspect of the thigh, that's what we call as greater trochanteric pain syndrome. So what is the cause of it? It's maybe the tendon of gluteus medius muscle has got inflamed, and because of inflammation of that, patient gets pain. The pain of this condition tends to occur at night, especially if they lie on that side. X-ray will be normal, but if you do an ultrasound, that will say that the trochanteric bursa has got inflamed, or this gluteus medius tendon has got inflamed. So common in female above 45, pain on the outside hip, pain on lying on that side, pain climbing stairs, getting in and out of the car, and localized tenderness on the lateral aspect of the hip over the greater trochanter. Treatment, you can start with paracetamol, little bit of anti-inflammatories. Physiotherapy is the first line treatment. Sometimes we can also insert a steroid injection into the bursa or into the tendon that can also relieve the pain. But the main treatment, paracetamol, NSAID, physiotherapy. Okay? So that finish your hip pain. Any question, guys? Excuse me. There is one other thing, osteomyelitis in children. It will be very difficult to differentiate osteomyelitis and septic arthritis because both of the children will have acute presentation. But the main thing that you should look for in osteomyelitis is a point tenderness. So septic arthritis, you can't pinpoint a specific tender area. But osteomyelitis, there will be a specific point tenderness. If that is there, then you should think of osteomyelitis. Okay? Which antibiotic for septic? Usually flucloxacillin or dicloxacillin IV. If osteoarthritis, the first movement that will be restricted is internal rotation. You don't need to remember the pathology of every disease. It's just for your understanding. Okay, good. Let's take a 10-minute break and then we start with leg. Thank you. All right, everyone, let's start again. Leg pain. There will be a lot of pain today, so bear with me. So, leg pain, again, this is also another important chapter. So, there's a lot of causes of leg pains, right? So, the pain can start from hip, knee, foot, anywhere. So, how do we know that what is neurological pain, what is vascular pain? That's important. So, nerve entrapment is suggested by a radiating burning pain, which is prominent at night and worse at rest. So radiating burning pain is nerve entrapment pain. Okay. Then there are vascular claudication, which can also cause the same kind of pain, but that pain is usually kind of, it's not a burning pain, but the patient will get kind of a ischemic pain, which is sharp stabbing kind of pain. Now let's move on to the causes of pain. So first of all, we will talk about the vascular claudications. Acute severe ischemia. So if a patient has got acute ischemia of the lower leg arteries, which is also what we call as peripheral vascular disease, it can be due to either a thrombus or an embolism of the arteries of the lower leg. So let's say that this is obviously the arteries of the lower leg. If there is a thrombus which is obstructing the blood flow, then the whole leg can get ischemic. Okay. Or there might be a emboli coming from the heart and now blocking the leg arteries. So this kind of patient will present to you with a sudden onset of severe pain in the lower leg. There are other patients, which is the chronic ischemic patient, which means they have like a, see the narrowed vessels over here. So because of atherosclerosis, the blood flow over this area is restricted. And sometimes if a patient walks or does some activities, then the pain gets worse because it is already narrowed. And when someone walks, they need more oxygen into the legs. So during walking, the pain gets worse. So chronic ischemia usually manifests as intermittent claudication. And intermittent claudication is pain in the leg while walking and gets better after taking a rest. Sometimes when it gets a little bit more advanced, they start to get rest pain at night. Now, there are few areas where the ischemia is common. You can see that sometimes patient can have ischemia of the aortoiliac arteries, so more proximal arteries. And if someone gets ischemia in this area, then the pain will start on the buttock and thigh, and then it goes down. If someone has got ischemia on the thigh arteries, which is the common femoral arteries, then the pain will be in the calf. Okay, so it's the pain is always distal to the site of obstruction. Okay, so that means that if a patient presents to you with a pain in the calf after walking, you will not think that this artery has got blocked. You will think that a little bit more proximal, most likely the thigh artery, which is the femoral artery, most likely that's where the patient having the problem. Okay. Now, how to differentiate between a neurogenic claudication and vascular claudication? Neurogenic claudication is what we call as a spinal canal stenosis. Spinal canal stenosis means the canal where the spinal cord is there. So if it's look, so this is the spinal canal, right? The yellow marking that you see. And sometimes either it's a disc prolapse or patient having lots of degeneration. Sometimes this canal can get compressed. And if canal gets compressed, then the spinal cord which goes through this canal, that can get compressed as well. Okay. So when a spinal cord gets compressed, patient starts to get this kind of pain that starts from their lower back and then that goes to their leg. And that pain also can start while walking. But neurogenic claudication, the cause is spinal canal stenosis, and vascular claudication, it means peripheral vascular disease. Long history of back pain is common in a spinal canal stenosis patient. And it's a proximal location. So pain will be obviously on the back, then buttock, and then to the legs. Whereas the vascular claudication, most of the time it starts on the foot and calf and then goes proximally. The type of pain in neurogenic claudication is burning, numbing, weakness, tingling, never cramping. But cramping pain is usually the main presentation of vascular claudication. Both uphill and downhill walking can make it worse. But vascular, you understand that if you walk uphill, you need more oxygen to the leg. So uphill walking will make it worse in vascular claudication. Relief of pain, usually after a patient lie down, then the neurogenic claudication pain can get better, but it takes a little bit more time to get relieved. Whereas in vascular claudication, usually if a patient stops walking, within few minutes, patient starts to feel better. Other associated features, obviously, you can get some neurological finding, like sometimes knee jerk, ankle jerk can be reduced. You can also get bowel bladder symptoms in neurogenic claudication. And other things in vascular claudication, patient can have peripheral pulse can be absent in this case, okay? But obviously pulse will be normal in neurogenic claudication. Neurological finding will not be there in vascular, whereas neurological finding can be there in spinal canal stenosis. How to diagnose this? You can do, first of all, this is a spinal canal stenosis. The best test is MRI, right? Because that can confirm canal stenosis. And you can also do electromyogram. But for vascular claudication, you'll need to look at the vessel blood flow. So how we do that? We do a peripheral arteries Doppler ultrasound or duplex ultrasound. Okay, so Doppler or duplex is same. So Doppler or duplex ultrasound of peripheral arteries, that will be your investigation of choice. But that's your initial investigations. What's your best investigation for vascular claudication? Arteriography. We'll come to that point later on, just in a bit. So go through these things, that what kind of things are related to the pain. So if worse on standing, consider a spinal cause. Worse on lying down, consider the vascular cause. Now, remember we discussed about the upper limb dermatome. So lower limb dermatome also important to remember a little bit. So if you look over here, starting with the lumbar tree. So if we see, let's say this is your knee, and that's your foot. So let's say this is the knee joint. The anterior portion of your thigh is given by lumbar 2. Anterior portion of your knee is lumbar 3. Medial aspect of the leg is lumbar 4. Lateral aspect of the leg is lumbar 5. Dorsum of the foot is lumbar 5, except the lateral aspect of the dorsum of the foot is S1. Okay, so that's the main dermatome of lower leg. So what are the main function of these dermatomes or of this nerve root? So L3, it helps with extension of the knee joint. L4 helps with flexion of the knee joint. It also helps with foot inversion. L5 helps with dorsiflexion of the great toe and ankle. So L5 is really important because L5 radiculopathy or neuropathy, it can cause weakness of the dorsiflexion of the foot. And if a patient is unable to do dorsiflexion of the foot, they get foot drop. Okay, so one of the differential diagnoses of foot drop is L5 nerve compression. Okay, and then S1, it helps with plantar flexion and eversion of the foot. So you should remember the specific motor function of these nerve roots. The sensation you already understand, depending on the dermatome that I have discussed. These are the areas where they give sensation. What is the knee jerk root value? L3, L4. And what is the ankle jerk root value? S1 and S2, which means L5 doesn't have any ankle or knee jerk. Okay, so I said that for knee jerk, your root value is L3, L4, and for ankle jerk, your root value is L5 and S1. Sorry, S1 and S2. So L5 doesn't give any reflex. So get some idea about this L5 S1 radiculopathy because this comes in exam. Sciatica. So we already know what is sciatica. We discussed in the last class. So what can happen that either the sciatic nerve or its branches, which is L4, L5, S1, S2, S3, any of this nerve root, if it is gets compressed, patient can get a shooting pain from the lower back going down to the foot. Acute sciatica, usually up to 12 weeks. Most of the time, spontaneous recovery can be expected. So you usually do a conservative treatment for these 3 months. So back education, relative bed rest, return to activities. So main thing is return to activities, offer some general painkiller, and maybe 2 weeks of NSAID. That's it. If patient is not responding to the circumstance, is not responding, or circumstances demand more active treatment, sometimes even an epidural anesthetic is appropriate. Okay. Next, lumbar spinal canal stenosis, the one that we just discussed, which causes neurogenic claudication, right? How the pain usually starts. So the pain, which is usually bilateral, the patient will have low back pain, and the pain will travel through the both leg. So it start proximal buttock, like start with the buttock, then the thigh, then to the leg, and then to the calf. So, but it will affect the both side. That's the most important part. In this situation, also you can start with conservative treatment like rest, exercise, analgesics, and even some medication for neuropathic pain. If it is severe or there is progressive neurological deficit, then you refer the patient to orthopedic spine doctor. Now we are going to discuss some neuropathy related to the foot or leg very quickly. You just need to know how to diagnose them. One of them is commonly asked in exam, meralgia paresthetica. So meralgia paresthetica is the commonest lower limb nerve entrapment. So you see this one, it is called lateral cutaneous nerve of the thigh. So when the lateral cutaneous nerve of the thigh gets compressed, so this is the inguinal ligament, the lateral end of the inguinal ligament, if this lateral femoral cutaneous nerve gets compressed, then the patient will get a like a burning, tingling numbness sensation on the lateral aspect of the thigh, just on this area. Okay. So the distribution of pain is confined to a localized area of the lateral thigh and it doesn't cross the midline of the thigh. So it should not cross the midline. Okay. It can be associated with obesity, pregnancy, ascites, or even sometimes local trauma with tight belts. Okay. So the treatment injection of a steroid can be done. If needed, then surgical release can be done as a last resort. Next, common peroneal nerve entrapment. Very important, comes in exam so frequently. So first of all, you need to have a basic idea about common peroneal nerve. Let's show you a picture so that you understand. So what you see here, that sciatic nerve, it originates from the lumbosacral plexus, right? And if you look on this side, so this is your sciatic nerve, which you can see it starts from the lumbosacral plexus. It goes down to the back of your thigh, and then around the knee joint, it divides into two nerves. And that two nerve is common peroneal nerve and tibial nerve. Let's have a look on this one. So this is the sciatic nerve at the back of your knee. It becomes common peroneal nerve and tibial nerve. Tibial nerve supplies the back of your calf, and it helps with plantar flexion of your foot. Whereas common peroneal nerve, it goes to the anterior portion of your leg. So like this. So you can see it's coming from the back, and around the head of the fibula, it comes to your anterior portion of the leg and supplies the anterior part of the leg. Okay? Is this understandable for everyone? Good. Now, if you look closely here, this one is not a good picture, like this one. So this common peroneal nerve, you can see it has divided into two branches. So these are called deep peroneal nerve and superficial peroneal nerve. Okay. So this is the main nervous or peripheral nervous system of your lower leg. Okay. Now, so you understand that this is actually the worst area. So prolonged squatting, like patient who does a lot of strawberry picking or anything which involves prolonged squatting, it can cause compression of this nerve at the head of the fibula, or even someone has got a trauma to the head of the fibula can cause common peroneal nerve entrapment. That's the time patient comes to you with this neuropathy. So how they present? Patient will come to you with the tingling, numbness, burning sensation at the anterior portion of the leg, down to the foot. They will have also some sensory issues, like sometimes loss of sensation or funny feeling. The main motor function loss will be because common peroneal nerve version and dorsiflexion. I think I did discuss about this in our trial class. So if you missed it, go through that. So eversion and dorsiflexion of the foot, this will be the one that will be weaker. Okay. So that's your common peroneal nerve entrapment. Treatment, sometimes you can give some shoe wedging or orthotics to maintain the eversion, and most effective treatment is neurolysis. Okay, so we discussed about common peroneal nerve entrapment. Now there is tarsal tunnel syndrome. So what is tarsal tunnel syndrome? Remember I told you the posterior tibial nerve. So posterior tibial nerve, which goes to the back of your calf, and it comes over here, and this is the tarsal tunnel, okay? And it goes under the tunnel to supply your foot. So if the posterior tibial nerve get compressed at the tarsal tunnel, that is what we call as tarsal tunnel syndrome. Do you understand? Patient will have a tingling, numbness, burning pain in the toes and sole of the foot. And even it can go down to the down, like it can go up to the calf. Patient will complain discomfort in bed at night and worse after standing. Sensory loss will be variable, especially on the back of the calf. There can be some. If you do a tenal tap test, that will be positive, and the diagnosis confirmed by electrodiagnosis, which is nerve conduction study or EMG. But again, the same thing, you will do tenal tap test, then ultrasound, then nerve conduction studies. Okay. Now, moving on again to occlusive or vascular disease, which is peripheral vascular disease. You know about the risk factor of peripheral vascular disease. Most importantly is smoking. Then some others you can go through. We were talking a little bit about the acute lower limb ischemia, right? So acute lower limb ischemia is not something that's good. It is a sudden dramatic event that requires immediate diagnosis. Otherwise, patient can have an amputation of that leg. So the commonest site of acute occlusion is the common femoral artery. That means at the thigh. There are 6 P's of acute lower limb ischemia, which is pain, pallor, paresthesia or numbness, pulselessness, paralysis, and perishing cold. Question asks you that what is the most important sign of acute lower limb ischemia? Paralysis and muscle compartment pain is the most important sign. Which one is more, paralysis or pain? Paralysis. If there is paralysis, it's the worst. So either paralysis or pain is the most important and ominous sign of acute lower limb ischemia. Golden rules. If a patient has developed acute lower limb ischemia, you have to treat it within 4 hours. Left untreated for 6 hours, which is the golden hours, patient will go for limb amputation. So if you diagnose them, then immediately you start with intravenous heparin, and if possible, then emergency embolectomy or stenting or arterial bypass. And this patient will need lifelong anticoagulation with warfarin. Okay, so you just need to remember these names. So intravenous heparin or emergency embolectomy. If embolectomy is not possible, then either stenting or bypass. That's acute lower limb ischemia. Following that, chronic lower limb ischemia. So you know that this patient will have intermittent claudication. So it's not acute. Chronic pain will be there. So they can have intermittent claudication, wrist pain, and sometimes even ulcer or gangrene. So what is intermittent claudication? It's the pain in the calf muscle after walking or exercise, which is relieved by rest. But there is wrist pain also, which is a constant severe burning pain or discomfort at rest, especially at night time. Okay. Now, we already know that if there is aortoiliac artery obstruction, patient will have pain on their buttock and thigh. So depending on where is the obstruction, the pain will be distal to that. And we know that superficial femoral artery, it's usually the commonest area of obstruction. So go through these things. Lots of causes are there, but main cause is atherosclerosis. Investigation. So first investigation or initial is Doppler ultrasound. And using the Doppler, we will also assess the ankle brachial index, so ABI. ABI is very important to assess the chronic lower limb ischemia. So normal value of ABI is 0.9 to 1.1. Less than 0.9 will give you the diagnosis of chronic lower limb ischemia. If it is less than 0.5, that's bad. That's need a vascular surgeon referral immediately. Okay. Now, sometimes they can ask you what is the most appropriate investigation for like chronic lower limb ischemia. We know that initial is Doppler or duplex ultrasound, but the confirmatory is CT angiogram. Okay, so CT angiogram will be your gold standard investigation. The only time we will go for arteriography. So arteriography means it's an invasive one, which means a catheter will be inserted, and then we can directly look where exactly is the obstruction. And even during that time, either you can do an embolectomy or you can put a stent. That is only needed if a patient is having severe vascular ischemia, like if someone has got less than 0.5 ABI, having ongoing wrist pain, there is ulcer, gangrene on the foot, that patient will need to be sent to a vascular surgeon and they will do that arteriography. But before arteriography, the non-invasive one, which can confirm the diagnosis, is CT angiogram. Okay, so you can just insert a dye and dye will be able to say how much blockage is there. Okay, So initial color Doppler, and then your confirmatory is CT angiogram. Unless a patient having severe symptoms, then the confirmatory will be arteriography. Treatment. Prevention is the most important thing. So smoking should be a stop. That's the first thing. And then we can also ask the patient to go for some supervised exercise. So you can see here, arteriography should be performed only if surgery is needed. There must be absolutely no smoking, daily graduated exercise. You can start the patient with aspirin. If there is any medication which can constrict the vessel, like if a patient is on beta blocker, which is contraindicated in peripheral vascular disease, you need to stop that. Okay. So if it is, let's say, 0.5 to 0.9, your management is conservative treatment. So risk factor modification. If it is less than 0.5, then intervention will be needed. So we refer the patient to vascular surgeon. So these are the criteria of referral. Go through that. Surgery. So there are lots of surgical options there, either stenting or bypass grafting. Okay. We normally say bypass is usually indicated if it is proximal obstruction. If it is distal obstruction, like after the cuff or just in the cuff, if there is obstruction, then stenting is usually the ideal one. So stenting only can be done for very, very localized, limited occlusions. But when it is a proximal one, then bypass grafting is ideal. Most common cause of acute lower limb ischemia, thrombus. So atherosclerosis should be the main cause. Okay, varicose veins. So all of you know about the varicose veins. So it's a dilated, tortuous, superficial vein in the lower extremities. There are lots of risk factors in here. You can go through that. Prevention, ideal weight, high fiber diet, elastic stockings, all is fine. So for varicose vein, the initial treatment is most of the time compression stockings. Keep the leg elevated. Okay. And then there are some other options. Let's say you have tried the initial compression stockings and everything, but it's ongoing. If it is a smaller below the knee joint, so a smaller below knee varicose vein, you can try sclerotherapy. But the best treatment for like a resistant varicose vein is surgical ligation and stripping. So you just need to remember the name of this surgery because it comes in exam. Which anticoagulant is preferred? Heparin. Superficial thrombophlebitis. So when the superficial vein gets infected, the patient can present to you with a tender red subcutaneous cord in the leg. So patient who has a known varicose vein suddenly presenting to you with a acute red tender cord on the leg. Then you think of superficial thrombophlebitis. Now, unless there is an extension of this above the level of knee, symptomatic treatment is the only thing that you need to do. But when a patient has got superficial thrombophlebitis, there is a likely chance they can have an underlying deep vein thrombosis. So a venous duplex scan. So we do two types of duplex. One is arterial, which looks at the artery, and then there is venous, which looks at the venous. And obviously, superficial thrombophlebitis is the inflammation of superficial vein. So you have to do a venous duplex. Treatment, apply a firm elastic bandage, bed rest. If it is due to a IV infusion, then you can prescribe NSAID or even a topical NSAID. If it is a spontaneous, then we put the patient on low molecular weight heparin for 4 weeks. Okay. The reason behind it that most of the time, if it is a spontaneous thrombophlebitis, there is a likelihood of underlying deep vein thrombosis. Okay, or it can be a deep vein thrombosis if you keep it without any blood thinner. All good. Any question, guys? Compression stockings cannot be given if a patient with a, let's say this patient has got varicose vein, but also has got a peripheral vascular disease. In those situations, especially if ABI less than 0.7, you can't go for compression stockings. Okay, there is still a lot of pain available. So let's go through that first. If you open up chapter 56, that's the painful knee joint. The only two things we are left with now is painful knee and painful foot. Let's see how much we can finish today. So painful knee, it's not super important, but few things we should know. So go through these key facts and checkpoints. Now, one of the few things which we should know of is that a ruptured anterior cruciate ligament is commonly comes with like immediate swelling of your knee joint. So a rapid onset of painful knee swelling within the first 4 hours after injury indicates likelihood of ACL rupture. Okay, so that's the anterior cruciate ligament rupture. If swelling comes up after 1 to 2 days, likely it's a synovial fluid inflammation. So go through this, it will be a little bit helpful for you. Even before that, you should know the common knee structures. Have a look on this. So what you see is the knee joint. And knee joint is stabilized by some ligaments, some meniscus. So on the both side, sorry, on the both side of the knee, you have got collateral ligament. So inner side, you have got medial collateral ligament, lateral side, lateral collateral ligament. Then there is this X-shaped ligament. The front one is anterior cruciate ligament, and the posterior one is posterior cruciate ligament. And in between the two bones, there is medial meniscus on the medial side, and then there is lateral meniscus, which helps the bone from bone to bone friction. Okay, so these are the three structures which is commonly injured in case of knee injury, or patient can even get a fracture. Okay, now moving on, after understanding those things, you can go through this initial part by yourself. Locking. So there's few terms that you will get in knee pain. So locking means sudden inability to extend the knee fully. So if a patient is able to flex the knee properly but unable to extend the knee, that's called locking. The true locking happens in torn meniscus, so bucket handle tear of the meniscus. Other than meniscus tear, there are a few other things which can also cause it, but most importantly, if a patient is unable to do the full extension of the knee after a trauma, you should suspect meniscus tear. So there is a lot of tests that we do to find out the ligament injuries. We'll come to that later on. Next, in children, there is a condition called OSD, Osgood-Schlatter disease. So Osgood-Schlatter disease, it's called traction apophysitis, resulting from repetitive traction stress at the insertion of the patellar tendon in the tibial tubercle. So what that means, see this one, that this is the patella, and that's your patellar tendon. Patellar tendon, it connects the patella with the tibial tuberosity. Now, because of repetitive strain, sometimes this tendon can also get strained or inflamed. Okay, that's what we call as Osgood-Schlatter disease. So it's common in children between 10 to 14 who are athletics. Okay, localized anterior knee pain in the region of tibial tubercle during and after activity. So that's the main presentation. Because it's tender over here, so it will get aggravated after kneeling down and going up and down the stairs. Even sometimes there might be a lump which is tender over here. Okay. What you can do X-ray to confirm the diagnosis. Management. This is a conservative management because it's a self-limiting condition. It can even take a year to get better. So in acute stage is mainly just a RICE treatment. So rest, ice, compression, elevation. And main thing is that patient needs to get some rest from active sports. So they can't do active sports because if they keep on doing it, it will just get worse. Localized treatment, such as electrotherapy, is unnecessary. Steroid injection should be avoided. Plaster cast should be avoided, and rarely surgery. The main thing is physiotherapy and some analgesics. That's Osgood-Schlatter disease. Moving on to acute knee injuries. So first of all, meniscus injury. So medial and lateral meniscus tear is not uncommon. It can happen very commonly. Which is more common? Medial meniscus tear. So most of the time it is contact sport like rugby, football players who will come to you with their meniscal tear. If you suspect meniscus tear, then X-ray is usually not helpful. You have to go for an MRI scan. Only the MRI can confirm medial meniscus or lateral meniscus tear. Okay? So patient will come to you with if it is a medial meniscus tear, then patient will have pain on the medial aspect of their knee. They can have locking, they will have knee swelling and loss of movement. Especially they will have restricted flexion. And they can obviously meniscus tear, patient can't do a full extension as well. Okay. Now, before we come to this parrot beak tear, those are not important for your exam. This is one of the other thing. A arthroscopic partial meniscectomy may offer relief in younger patients. So I will come to the point of treatment of meniscus tear, but very rarely we do a meniscus repair initially, unless it is a young active patient. Then sometimes the meniscus repair or even a partial meniscectomy can be done. So arthroscopic meniscectomy for a degenerative meniscal tear is one first-line treatment. But many times you can start with a physiotherapy as well. So how to differentiate between medial and lateral meniscus tear? Go through that in your own time. It's not very hard to know. But in terms of meniscus tear treatment, we will usually, if it is a like not an active person, not a young adult, not a young athlete, initial rest, analgesics, heat pack, sometimes even if they need some knee brace, that's fine, and then physio. Even after trying the physio, if it is still ongoing pain, then we can send the patient for meniscus repair or meniscectomy, which usually done by arthroscopy. Yeah. Especially if it's a locked knee, MRI is indicated. So that's your meniscus tear. Then anterior cruciate ligament rupture. Before we go for that, also you should know that for meniscus, there are some special physical examination finding. So we call is Thessaley test, McMurray's test, and Apley's grinding test. So if in the exam they say Apley's grinding test positive, then you know already that it is a meniscal tear that they are talking about. Okay, so remember this special test because these are the clues in the exam. Now, anterior cruciate ligament rupture. This is actually very serious and it can be quite disabling for a person because it can cause knee instability. Early diagnosis is important. So when an ACL rupture happens, most of the time it has to be very traumatic to get an ACL rupture. And we say that if the tibia rotates on a flexed knee, so if the knee was flexed and then patient's tibia rotated internally, that's the time usually they get an ACL rupture, like rugby tackle. Many times with ACL rupture, patient can also get medial collateral ligament tear and medial meniscus tear. Together, this three tier is called unhappy triad. So when a patient has got HCL rupture, look for these two, like medial meniscus and medial collateral ligament tear. So patient will come to you with a severe painful knee swelling within minutes to hours after the injury. So immediate effusion of blood, that's your diagnosis. And also, if you see that, you will see that the knee is giving away. So this is one of the clue to the ACL rupture, that knee giving way. That means knee is unstable. So on examination, gross swelling or effusion of the knee, joint line tenderness can be there, and you can do some test. So the test that we do is called anterior drawer test. Then there is pivot shift test, and the best test for ACL is Lachman test. So if Lachman test is positive, then you can think this is a ACL rupture. Okay. Management depends on the finding by the surgeon. Surgical repair is reserved for complete ligament tear, which is usually reconstruction. Early reconstruction is usually indicated for younger patients who participate in sports. For less active people, conservative approach is appropriate. Okay, so that means the same thing. PCL rupture not important, medial collateral ligament rupture. Now, if a patient get side tackled, then they can have a medial collateral ligament rupture. It happens in rugby, soccer, those kind of sports. So patient will have, again, pain on the medial aspect of the knee, aggravated by twisting. And they can also have effusion, localized swelling, all of these things can be there. But when you do a test, we call it a valgus stress test. If valgus stress test causes pain, that's medial collateral ligament tear. Okay, so that will be the important finding. Same in this case, management is initially rehabilitation exercise. Conservative treatment is usually the first thing that we would go for. So far clear, guys? Any question? Moving on to some of the important knee pain conditions. Time to time, it actually comes in exam, so you should know at least the presentation of these conditions. So first is patellofemoral pain syndrome. Patellofemoral pain syndrome has a lot of other names, but mainly it is a pain which comes from the anterior portion of the knee. It is known as anterior knee pain, jogger's knee, runner's knee, cyclist's knee, or even sometimes chondromalacia patella. So what happens in this case is that because of repetitive friction of the patella over the femur, that's why we call it patellofemoral syndrome. This is the femur, this is the patella. Because of repetitive friction of patella on femur, the articular cartilage can get inflamed or can have wear and tear, and that is what we call as patellofemoral pain syndrome. So obviously, this is more common in patients who use their knee more, like joggers, runners, etc. Okay. So clinical feature, pain behind or adjacent to the patella, or they sometimes say deep in the knee. Pain aggravated, which requires flexion of the knee, which means climbing stairs, walking down stairs, squatting, or prolonged sitting. Okay. So anything which needs prolonged flexion of the knee, that will cause pain. And there is a test we do called Parkin's test that will be also positive in this case. Treatment, reassurance, refer to physio, some painkiller, that's it. So the treatment usually doesn't come in exam. They give you a scenario and ask that what's your most likely diagnosis. Next is jumper's knee or patellar tendinopathy. Patellar tendinopathy is the inflammation of the patellar tendon. Okay, so you remember the patellar tendon which connects the patella to the tibia. So that patellar tendon can get inflamed, especially for patient who does repetitive jumping sports like high jump, basketball, volleyball, etc. So it also causes a gradual anterior knee pain, but pain is localized to the below knee. Because if you see here, so this is the patella and that's the patellar tendon. So if patellar tendon is inflamed, it will be just a below knee pain. So over here, the pain will be more common. The patient will complain below knee pain. Pain will get worse with activity and better with rest. And especially they will say with jumping, pain gets worse. That's why it is jumper knee. Management, conservative, rest from offending stress and referral to physio. OSD is children. Okay. So children who are athletic, they get OSD. And jumpers, these are more common in adult. And OSD, basically there will be tibial tuberosity tenderness. But this one is tenderness over the patellar tendon itself. What is iliotibial band syndrome? There is a thing called iliotibial band. So let's have a look first what exactly that means. So see that this is what we call as iliotibial band, which starts from your ASIS and then the whole lateral aspect of your thigh, and then it gets connected to the tibia. This iliotibial band that can get stressed. So inflammation develops over the lateral aspect of the knee where the iliotibial band passes over the lateral femoral condyle. So that's the main thing. So you can see here, this is the lateral femoral condyle over here. So there will be an inflammation over this area. Okay. So you understand that patient will come to you with a pain on the lateral aspect of their knee. And it is common in long distance runners, especially running up and down hills. So it presents with a well-localized lateral knee pain, and palpation reveals tenderness over the lateral condyle. So let's give you the diagnosis. When you have got a patient who is a long distance runner complaining lateral knee pain and it is tender over the lateral condyle, that's iliotibial band syndrome. Go through this pre-patellar bursitis, also known as housemaid's knee. Okay, this is for you to go through. That's all about the knee pain. Any question? Are you still getting the pain? You should be thinking what's happening around me, right? Because there's a lot of things to remember. Okay, let's finish with the pain in the foot and ankle. It should be quick. Pain in the foot and ankle, there are a few things that come in exam. So we'll go through those important ones. So initial things is for you to go through, not super important, but you can give it a read if you want. So ankle sprain, very common. Patient gets a inversion injury to the ankle and then comes to you with the ankle pain. And most of the time, ankle will give way, difficulty in weight bearing. Okay. Physical examination will show there is tenderness around the ankle. So most of the time, we don't need to do anything. Patient can be on an ankle brace and physiotherapy. Very important is to know about this Ottawa rule for ankle and foot x-ray. The important thing to know is that not every patient who comes to you with an ankle injury will need an x-ray. So there are few areas where only we will do it. So an x-ray of the ankle is necessary when a patient has pain over the medial or lateral malleolus. So these two, there is bony tenderness 6 centimeter above the medial and lateral malleolus. Let's show it from a picture. So this is the lateral malleolus, and let's say this is medial malleolus. So lateral malleolus, medial malleolus tenderness, and 6 centimeter above it. Okay. Gauge of the fifth metatarsal, this one, navicular bone. Okay. These are the main areas. So we say that base of the fifth metatarsal, navicular bone, medial and lateral malleolus, and 6 centimeter above it. That's the, if there is tenderness over these areas, then you should go for an ankle X-ray. Okay. And also, if patient there was an inability to bear weight, both immediately after injury and during the clinical exam. So inability to bear weight is also one of the indications. Management. So many times management depends, the ankle sprain depends on the severity of it. So you can see here, depending on the grade, the treatment will be different. You can go through that in your own time, it's fine. Achilles tendinopathy. So first of all, you should know where is the Achilles tendon. So the gastrocnemius and soleus muscle, that muscle, when it becomes tendon, is known as Achilles tendon. This is the Achilles tendon. So you understand now that the pain will be on the back of the leg or back of the foot. So tendinopathy means it's the inflammation of the Achilles tendon, which happens because of overuse or strain of that tendon. So patient will present with pain during and after weight bearing activities with a tender swelling of the tendon. Okay. And in this case, management is rest, NSAID, physiotherapy. But there are some times where a patient can have a rupture of the Achilles tendon. With the rupture of the Achilles tendon, patient will have a severe intense pain on that area. They can even just fall over. Swelling, bruising over will be there. But most importantly, if you do a Thompson test, that will be positive. Thompson test is ideally in a normal person, if you squeeze the calf, they will have a involuntary plantar flexion of the foot. But a patient who has got rupture of the Achilles tendon, even if you squeeze the calf, there will be no movement of the foot. Okay, let's give you the diagnosis. And that's usually needed early surgical repair. Very common is plantar fasciitis, commonly asked in exam also. It is also known as policeman's heel. So plantar fascia is the fascia that's on your sole, right? Have a look on the plantar fascia first. So you can see that with the heel bone, this is the fibrous sheath which is actually on your sole of the foot. And anywhere, this plantar fascia can get inflamed. But most commonly, it happens at the insertion of the calcaneum or heel bone. And many times, patient can have a calcaneal spar associated with it. So patient in here will come to you with a gradual onset of pain on the sole of the foot. And they say that the pain is under the heel. It gets better after walking, but first step out of the bed is the worst. Sometimes they say it feels like I'm walking on a pebble or a stone. And worse after sitting. Okay. So many times it can be related to the footwear also. If you examine the patient, there will be localized tenderness on the plantar fascia. Treatment, plantar fasciitis, so it might need 12 to 24 months to get better. So a lot of treatment is available. You can give some painkiller, steroid injection, sometimes rest from walking. Sometimes even we can go for some plantar fascia stretching exercise. Okay. There is insoles that can be given. So a lot of options are there that can be tried. But main thing is diagnosis. So if a patient comes to you with a pain on the sole, which get worse first thing out of the bed, and gradually after activity gets better, but then again at the end of the day it's getting worse, then you think of plantar fasciitis. Give a read of this tibialis posterior tendinopathy. Stress fracture. Very important is to know about the stress fracture of the foot. So as I think we might discuss this stress fracture somewhere else. So patient with a stress fracture, commonly navicular bone can get a stress fracture. They have a slow, gradual onset of pain on the midfoot. It's common in ballet dancers and unfit people taking up exercise. On examination, you might not get any finding. You do an X-ray, sometimes normal. Only way to confirm the diagnosis is bone scan. And the treatment is absolute rest for 6 weeks with a strong supportive footwear. The other one, which is important for exam, is called Morton neuroma. Morton neuroma is nothing but it's a fibrous enlargement of the interdigital nerve. So let me show you what it is. So see that this is the interdigital space. In between each of these bones, this interdigital space has got interdigital nerve. If this interdigital nerve gets fibrous thickening, or fibrous enlargement that can give a pain. The pain is very typical. They get a severe burning pain, like a sharp shooting pain, and it's common between fourth and second and third toes. Okay, so patient will come to you with this burning sharp pain on the foot, worse on weight bearing on hard surface, aggravated by wearing tight shoes. Okay, and if you take the metatarsal heads, so if you press on this area, it will be tender. Treatment, patient in this case, we should advise to wear loose shoes with a low heel and use a sponge rubber metatarsal pad. Sometimes you can also give them some orthotics that should do. Ingrown toenail. If a patient has got ingrown toenail, usually management comes. The first line management is conservative. So what they can do is that they can go for a topical antiseptic ointment. If there is surrounding cellulitis, even oral antibiotic can be tried. Okay. The main thing is to cut the nail properly to prevent it to happen. But if conservative treatment doesn't help, then you will need to go for surgery. So what are the surgical options for ingrown toenail? You can do excision of ellipse of skin. You can burn that area by electrocauterization. You can do a wedge excision. You can do wedge nail excision and phenolization. Okay. Now, none of this is usually what comes in exam. So what we normally do, we just do a wedge excision of the nail. We should never go for a full nail removal. It's very unusual that we will do it. So if question asked for what is the best treatment, that will be wedge excision of the nail. That's it. So that's all the things that we need you to know. And hopefully you should be fine. The investigation for anything related to tendon initially is always ultrasound and best is MRI. Okay. Hopefully you were able to understand. I know it is very difficult, and I know that you can't remember what we have discussed. But what I would suggest is that please go through that as early as possible so that you can at least remember what was discussed. Because after a week, you will forget everything I say. And Dr. Namra, in surgery vignettes, do we go through all the trauma topics? Yes, please go through all the trauma topics, but especially the trauma that we have discussed. Okay? Like the neurologic, the ones that we haven't even touched that you don't need to go through. All good. Let's finish it here tonight, guys. Take care.